So I'm presenting a presentation on how health professionals are failing detransitioners, and by extension, failing everyone who accesses gendered medicine. This is my opinion, and I don't speak for every detransitioner, just as a disclaimer. So three areas I'm going to go over are the low quality evidence for the efficacy of transition, the informed consent model and how it's not actually fully informed, and the last section is on the lack of support for detransitioners. The first failure is the failure to provide evidence-based treatment. There's been a recent shift from treating dysphoria to providing gender-affirming care, and it's activist motivated, it's not evidence-based. There's little longitudinal research on the effects of cross-sex hormones, and due to lack of follow-up, regret in detransition is not well studied. The second area of failure is the failure to obtain true informed consent. There's no process of differential diagnosis. There's no exploration of any issues that might affect identity. And there's no evidence that youth in particular can meaningfully consent to the lifelong effects of medical transition. And finally, the last failure is a failure to prepare support for detransitioners. No one seems to know what to say or what resources to offer. So what is it that detransitioners need from healthcare professionals? So the first section is about low quality evidence. And I think it's worth mentioning that when we talk about evidence-based treatment, most psychiatric conditions have a low quality evidence base. They're not considered, like therapy is not considered evidence-based often because there's no empirical measurements of it. It's not like other medicine like cancer. You can measure the cancer, you can see when it goes away. This is true for all psychiatric conditions, I think, but I think what's really important about this is that you need to have a really, really good evidence base in place if you're going to go straight to an invasive treatment that is going to cause permanent changes to your body. Medical transition was originally meant to treat a psychiatric condition. Broadly, it's distress regarding one's sex characteristics or the desire to live as the opposite sex. More recently, they might say, or as another gender. The diagnostic criteria also outlined the minimum length of time that the criteria must be present for diagnosis and that it must be associated with clinically significant distress in areas of functioning. And access to transition historically involved a lot more gatekeeping measures, what they would call gatekeeping, what I might call safeguarding. So requiring referrals, talk therapy, a mental health evaluation, etc. Meanwhile, in the last decade, there's been a shift from treating a condition, gender dysphoria in the most recent DSM, to affirming gender identities. Now, the concept of a gender identity as it's used today it's sort of evolved within postmodernist queer theory. So postmodernism rejects the idea of an objective truth, and it believes that all subjective realities are true. If you feel like a woman, you are one. Really, if you feel like anything, you are that. That sort of idea, and queer theory is concerned with challenging what is normal within gender and sexuality. But in essence, what happened is an objective diagnosis has been replaced with a subjective identity, which can't be questioned anymore or, looked into or measured. So I say that transition has gone from being a treatment to being a service. Gender dysphoria, when it was a treatment, gender dysphoria has diagnostic criteria. If the patient's symptoms diminish, we can say the treatment worked. If the patient didn't improve, we can say the treatment didn't work. If the patient worsened, we might be able to suggest that some of the fault lies with the doctor if they weren't careful determining which treatment was the best option. And so gender identity is whatever a patient says it is. So when I say it's a service for people who say that they're a transgender, who their only purpose for showing up is their gender identity, in terms of getting access to that service, basically. If transition is no longer a treatment, it is simply a service. If the patient isn't happy afterwards, they can only blame themselves. So this is where they're sort of taking the duty of care is being offloaded off of doctors and onto the patients themselves. And it doesn't seem like maybe not so much a big deal for adults, but when you think about the fact that there are children that are doing this now, and these doctors are just, allowing them to sign away all of their, the liability, basically, I just feel like it's so unfair. Doctors don't have to determine whether it's the best treatment because denying it to someone is a violation of their bodily autonomy. I don't agree with this, but that's the purpose basically, is they believe it's a violation of their right to bodily autonomy. This shift was activist driven. It wasn't evidence based. So we didn't suddenly get evidence that proved that anyone who says they're trans is the opposite sex or another gender. There's no empirical evidence of that. So that never happened. The whole thing was really activist driven. So coming from lived experiences instead of empirical evidence. So if we had empirical proof to measure a gender identity, it might make sense to facilitate transition as quickly as possible. And empirical proof could have been like a brain scan or measuring hormone levels or doing a blood test, but like we don't have anything like that. It just doesn't exist. The measurement that determines whether someone is truly transgender is that person's satisfaction with transition. That's what all of the studies are looking at, is did their mental health get better? Are they happy with it? And that's the only measurement they have. So the shift from treatment to service means that doctors aren't obliged to determine whether someone is truly transgender or not. In other words, they're not really required to diagnose them anymore. There is little research on how medical transition affects a person's quality of life in the long term. The studies just aren't there. Most studies showing satisfaction are only following up a few years after starting transition. If you followed up with me a few years after I started transition, I would have told you I was happy. I would have told you I was happy probably up until 9 years following transition. The longest follow-up study, which was in 2011, spans 30 years and showed that the suicide rate 10 to 15 years after surgery was almost 20 times higher than the general population. So that's pretty important. I mean, if we're doing this to prevent suicide, but the suicide rate is still so high, then what are we actually treating? And I have sources. So that's my source at the bottom for that long-term study. And the one underneath it is the Stats for Gender website that has all of this information about what the quality of the research looks like. Most studies that conclude low regret were conducted before the explosion of trans-identifying patients circa 2015. And they were most of them were specifically about surgery regret. So we can't make conclusions about pediatric transition because most of these people were not transitioning as children. We can't make conclusions about the informed consent model because the people who they were studying didn't go through this informed consent model. They went through those gatekeeping measures way back when. And we can't make conclusions about adolescent onset gender dysphoria or rapid onset gender dysphoria because if I remember correctly, most of these people were either childhood onset or they were already adults. So it's a completely new cohort that we don't really know very much about. And that source is a systematic review of regret. That article looked at about 27 different studies that were looking at regret, and I think they were all post-surgery, but only there 27, and I think only about maybe 5 or 6 were in the last 10 years. Almost all of them were before then. And estimates of detransition and regret are unreliable because many detransitioners don't tell their health professionals. Many professionals are not following up with their patients. Many studies have high loss to follow-up, which is greater than 20%. We don't know if those people detransitioned. They might have just gone elsewhere. They might still be identifying as trans. They might regret it. They might have detransitioned. Nobody knows. Puberty blockers led to little or no change in gender dysphoria, mental health, body image, and psychosocial functioning. The landmark Dutch study from 2011 was considered at high risk of bias and of poor quality overall. All the studies evaluated had results of very low certainty and were subject to bias and confounding. Cross-sex hormones, this was for, I think it was specifically for youth. Uncontrolled studies meant any changes in scores from baseline to follow-up could be attributed to regression to the mean rather than the beneficial effects of hormones. So because they didn't have any control groups, we just don't really know what caused any of the changes. Hormones may improve symptoms of gender dysphoria, mental health, and psychosocial functioning, but caution that potential benefits are of very low certainty and must be weighed against the largely unknown long-term safety profile of these treatments. So once again, that was from SEGM's website, where they sort of summarized that. So the ethical dilemma around detransition, we have the trans rights activist position. And so their position, and I have a source for this, their position is generally transition regret or detransition is impossible to predict. Therefore, it is unethical to try and prevent that outcome, for example, with gatekeeping, because regret is rare and gatekeeping might harm people who will benefit from transition, either by causing further emotional distress or by violating their right to personal autonomy. That's their position. My position as a detransitioner is that transition regret or detransition is impossible to predict. We do agree on that premise. Therefore, it is unethical to treat an invasive treatment as the preferred option because the evidence base for transition is low quality, because transition is socially, physically, and mentally difficult on every single person that does it, because most people who pursue transition are desperate and psychologically vulnerable, and because each of us only gets one body in our lifetime. The source at the bottom is from local trans activists, and basically they're making the argument that I pointed out in that first paragraph. They also say that specifically that they think there is very little evidence that detransition is a medical failure. And obviously I completely agree with that. And this is my argument against that. This section is about informed consent. The informed consent model of transgender care. It's important to point out that this model is not the same as informed consent in medicine, and I'm going to get to that definition as well. So the model for transgender care, it's part of a political push to depathologize identifying as transgender. So as I said in the previous part, it's not a condition anymore. It's not something you have, it's someone you are. It's an alternative to the standard model of care, which is recommended by WPATH. The patient doesn't have to meet the diagnostic criteria for gender dysphoria. The patient doesn't need a referral from a mental health professional. Patient doesn't need to undergo a mental health evaluation. The risks and benefits are discussed, but no alternative options are considered. And that's my sources on those two. So I took the definition of informed consent in medicine from the American Medical Association's website. So in seeking a patient's informed consent, physicians should assess the patient's ability to understand relevant medical information and the implications of treatment alternatives, and to make an independent, voluntary decision. How is this going wrong in transgender healthcare? First of all, you have to be psychologically sound and developmentally capable of understanding and being able to make those decisions. So if you don't have a mental health evaluation, how do you know that someone is psychologically sound or developmentally capable? And in terms of the other part of developmentally capable, that seems to be a part where youth are also, especially minors specifically, are being not served as well, basically. I don't think that they're able to make that kind of decision personally. There are many unknowns in experimental treatment. So it's hard to be able to understand the sort of the implications or how this is going to affect you in the long term. If it's an experimental treatment, we don't know a whole lot. No alternative treatments are presented. So we don't know the implications of anything else, basically any other treatment of doing therapy or of not even doing anything at all, which is something that gets covered on the next page. The second part, in seeking a patient's informed consent, physicians should present relevant information accurately and sensitively in keeping with the patient's preferences for receiving medical information. The physician should include information about the diagnosis when known, the nature and purpose of recommended interventions, and the burdens, risks, and expected benefits of all options, including foregoing treatment. So where we're failing here is there is no diagnosis required. People are essentially self-diagnosing, but they would probably say they're self-identifying, but still it's the same thing. What is the purpose if there is no diagnosis? So how do we talk about what the nature and purpose of a recommended intervention is if there is no diagnosis? And once again, there's no alternative treatments presented. So how can you know the burdens, risks, and benefits of all of your options if you're only being given the one option? And that's sort of the thing with gender affirming care, is you affirm, 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 and there's no questioning. They don't even think about it, essentially. The last section of that was that physicians should document the informed consent conversation and the patient's decision in the medical record. I don't think there's any issue there, so I didn't add anything. Activists hinge the importance of making hormones and surgery easily accessible via, and their goal is eventually everywhere to have the informed consent model, on the high rates of suicidal ideation in trans-identified people. Simultaneously, the model is meant to depathologize that same experience that is causing someone extreme emotional distress. So, how does this make sense? They're coming with extreme emotional distress, but you want to treat it like it's not a mental health problem. That doesn't make any sense. People who are at risk of hurting themselves are a vulnerable population who need to be treated with extra care when it comes to life-altering decisions. Without evaluation and assessment, a person's decision cannot be fully informed. Dysphoria is a psychiatric condition that can be affected by a number of other health concerns. Now, these are the WPATH standards of care. I don't agree with everything that's in there, but very critically, they point out this exact fact. They recommend screening for mental health concerns, including anxiety, depression, self-harm, a history of abuse and neglect, compulsivity, substance abuse, sexual concerns, personality disorders, eating disorders, psychotic disorders, and autistic spectrum disorders. In that same paragraph, it says, addressing these concerns can greatly facilitate the resolution of gender dysphoria, possible changes in gender role, the making of informed decisions about medical interventions, and improvements in quality of life. The informed consent model definitely veers off from what the WPATH standards of care were trying to achieve. So I'll talk about my own experience. I was prescribed hormones by a general practitioner via informed consent in October 2010. I never went to a gender identity clinic. I only saw my specific doctor. My clinic was, I would say, ideologically captured. It was very, the activists loved it, basically. I did require letters. I required letters from mental health professionals. They needed two from me. One of them had to recommend testosterone, and the other one confirmed that I was of sound mind. So the two people that did this, the first one that recommended testosterone, I was in a trans support group that was run by two trans therapists. At one meeting, they said that they knew a clinic that was looking for a trans man and a trans woman because their resident doctors wanted to get experience with transgender patients. So one of those therapists is the one who wrote me the letter recommending testosterone. He probably had an hour-long meeting with me before recommending testosterone. The other letter was from my regular therapist that I had been seeing elsewhere. She's not a gender therapist. And she also had never had a transgender patient before me. And she wrote a letter confirming that I was able to psychologically make the decision. I think it's important to note that she wasn't a doctor and she couldn't diagnose me with anything, because that comes into play later. It turns out that I had some, I think, mental health conditions that might not have allowed me to make such a decision, or at least made it, I was impulsive, basically. There was no formal mental health evaluation. I had been seeing a therapist for about 2 years, as I mentioned. I had a medical history of depression, anxiety, self-harm, suicidal ideation. I had a suicide plan a year prior. So in 2009, there was no screening for any other psychiatric concerns. And I was advised of some of testosterone's risks and effects, and I signed forms accepting those risks. And I say some of because I think we knew even less about what testosterone does to a female body in 2010. I definitely did not hear anything about atrophy. I didn't know anything about, I found out several years in to taking testosterone that hysterectomy is recommended if you're going to be on testosterone for long term, just because it does horrible things to your uterus, basically. And so things like that. And I don't think they even mentioned detransition. There was no talk about the risk of potentially regretting it later on. So compared to other people in my area, in 2010, most of the local trans people that I knew were going through the gender identity clinic at the Center for Addiction and Mental Health. This was Dr. Kenneth Zucker's clinic. He was still there at this time. And he is one of the people that helped write the WPATH standards of care. So CAMH more closely followed that standard model of care. They required referral from a mental health professional. It involved a mental health evaluation. Patients had to undergo a period of real life experience, meaning they had to live as their target gender before they could access hormones or surgery. And patients were denied access to medical transition if there were concerns that it might not benefit them. So for example, I knew people, trans women that said that if they wore pants to their interview, they were told that they couldn't transition. It was kind of a weird sexist thing going on. Or I knew a trans man whose name wasn't masculine enough. There were weird reasons. And I don't think we should necessarily go back to that model. In 2017, I underwent a psychoeducational assessment and I received several diagnoses that reshaped my understanding of myself, including developmental disabilities and experiencing post-traumatic stress symptoms. It was like seeing all of those pieces of the puzzle just all fitting suddenly and going, oh, that's why it all happened, sort of thing. So my autism diagnosis in particular was essential to understanding parts of my life. And I feel like I was robbed knowing that I could have had that knowledge 7 years earlier, because many of those feelings were things that I classified as being because I'm trans. So I thought I didn't fit in with girls because I'm trans, or I didn't like wearing dresses because I'm trans. I still didn't detransition for another few years after that. The psychologist who did the assessment affirmed my identity. So I have a 25-page assessment, and the psychologist used they, them pronouns for me throughout the whole thing and never questioned anything about my gender at all. So while I had some new answers, I still needed more time to figure out where everything fit. So this was sort of a map of what my gender identity exploration looked like in 2010, where I had all of these different reasons and I went, oh, it's because I'm trans. So I preferred male friends. Actually, when I was listening to Ali's talk, I said, oh, well, a lot of these are exactly like me, basically. I think the ones that are important to point out are that obsessive thinking about gender, being bullied as a child. There was trauma there, basically. At the bottom of the screen, I have this phrase that says, if you think you're trans, you are, which is what everyone online was telling me at that time. And really, they repeat it over and over and over. If you think you're trans, then you are. Or they'll also say that cis people don't question their gender so much, if you're questioning it, then you're definitely trans. So there was a lot of affirmation going on. And this is what my self-understanding looks like today. So that big green circle in the middle has been divided into all of these different reasons why all of these things were happening to me. And those orange boxes rather are things that I kind of figured out in addition after getting diagnoses, basically. Or so, for example, like dresses and clothing and not liking makeup, these are all sensory issues for me because I'm autistic. I was bullied because I'm autistic. I have ADHD. I made impulsive decisions, including the one to transition. Other things like being able to pass as a man helped with my anxiety. I didn't feel like I didn't have to smile as much. I didn't have to perform as much. So all of these things were sometimes because I'm autistic, because I have ADHD, because I had unresolved trauma and used escapism as a coping mechanism. Laura mentioned that also. Because I'm depressed, or because women are just sometimes often treated poorly, really. And right here at the bottom, I have a thing that says that wasn't entirely true, because as it turns out, I said a few things. I would say, that I didn't fit in the girls and that's why I'm trans. But to be fair, I didn't actually fit in with the boys either. I role played as male characters. but I actually role played as female characters too. So those are, I think, instances of me just lying to myself and not being entirely truthful about it. So I threw this in at the last second because the cast review interim report came out, and I saw this diagram that shows complex presentations of, I guess, gender questioning people on one side, and the many different pathways that those people could take on the other side. And I thought it was really important and very validating to see that there are a lot of different reasons that people show up at a gender identity clinic or show up saying, you know, I want to transition, or I think I'm trans, kind of thing. There's a lot of different reasons, as we've all heard today. Okay, my last section is on detransition support. So what do detransitioners want? For some detransitioners, transition was a form of medical trauma. I think people need to, specifically healthcare professionals, need to remember that sort of above all else. We need professionals that are prepared for detransitioners. This was also talked about earlier. Some of us have lost trust in healthcare professionals as a result of our experience. A doctor or therapist who seems like they're ahead of the game could help rebuild that trust, but one who appears to be scrambling for resources might not instill confidence. So preparation might include collecting information, pamphlets, websites, organizations that might be of interest to a detransitioner, facilitating support groups for people who have detransitioned, encouraging further research on the process of detransition and detransitioner needs. Information on how to safely medically detransition. So these sort of reflect the kind of questions that I see in the Detrans subreddit all the time. How do you taper off of hormones? What changes to expect and how soon? What hormone withdrawal might look like? Which effects of the hormones are permanent? Whether we're at risk of any diseases or other conditions because of our prescription history, and if and how our fertility has been affected. When discussing surgery, like reconstructive surgery, we need sensitivity to the fact that it has already failed us once. And I think it's not uncommon for detransitioners to say that they don't want to do surgery anymore. But for those of us that do, insurance coverage for reconstructive surgery and interventions. So for some examples, breast reconstruction for detrans females, mastectomy for detrans males that grew breasts, testicular prostheses if they've had an orchiectomy, hair transplants, electrolysis or laser hair removal, or voice feminization surgery. The research into other reconstructive options. So for example, can genital surgery ever be reversed? Probably not ever fully, but under what circumstances? And therapeutic support surrounding body image distress or continuing dysphoria, loss of fertility, dealing with feelings of guilt, shame, anger, hopelessness, and grief, isolation from their former community, deep programming from former beliefs, reintegrating into the world, or feeling behind in life and worrying about wasted time. We want to be able to define our experiences with the words that we choose. I picked this because some people think that the word detransition is stigmatizing, but I feel like it's really only stigmatizing to people who haven't detransitioned. Acknowledgement from professionals that detransitioners exist and deserve quality care like anyone else. Not having our experiences devalued by referencing how rare detransition is. It might be rare, but I'm just so tired of talking about detransition and then having someone show up and be like, oh, well, it's so rare, as if we don't as if we don't matter, essentially. And finally, compassion. None of us need someone saying, I told you so at the end of the day. I have 2 more slides. There's this one that has a whole bunch of resources. Detrans Voices Carol is involved with that. Gender Care Consumer Advocacy Network is Grace is the president, and Sinead is on the leadership board of Gender Dysphoria Alliance. And the last page has my contact information. That's it.